really very important topic now, which is the usual use of SBRT in the central ultracentral early lung cancer. As we have already started using for the peripheral for many years now, but what about the central and ultracentral, which is a bit risky? So again, I'll be talking about the global incidence of lung cancer in Bangladesh and in the world, and the role of the SBRT, and whether the SBRT can be an option for operable patients as well. So this is the first time actually in the GloboCan or globally that lung cancer is not number one more than breast cancer. It has been breast cancer for many years, the number one, but now the incidence is lung cancer. In Bangladesh, it's also in the top 5. In male, it is number 3, and male and female, of course, in females out of 5, but in male and female, it's number 3 as well. And you can see here, you have more than 13,000 new cases of lung cancer. So what's the role of the SBRT in general in early non-small lung cancer? It has been a standard for many years, as I mentioned, for early lung cancer, when you have tumors less than 4 or 5 cm with N0 and M0. So the SBRT is being standard of care for patients who are unfit for surgery or high risk for surgery, or simply patients who refuse surgery. So it's not the conventional way, 66 to 70 gray, the way to go, but it is the SBRT. And now, actually, we have emerging data to use it or to consider it even for some operable patients. Now, historically, we know that from the Chisel phase 3 trial, comparing the SBRT, and that's in general, peripheral and central, with the conventional, so the outcome was inferior when you consider the conventional radiotherapy. So SBRT was dramatically, the response was much better. And for this, it has been, the standard of care for many years, for probably now for more than 15 years. This is the famous publication in JAMA, where the SBRT has been, from that time, being considered as standard of care. With good local control and overall survival, as you can see from many studies that already published, using for in general, that's peripheral and the central tumors in the lung cancer. And from, I think, 2010 or 11, it has been there in the guidelines, and this is the latest one, in the NCCN guidelines, that the SBRT and not the conventional radiotherapy is a standard of care for tumors in stage 1 and stage 2A, where you have lesions less than 4 or 5 cm and with N0 and M0. So it is clearly, it is the indication there. And the regimen that we use, or radiotherapy, that the BED should be more than 100 gray, really, to have a good outcome. In some cases where the tumor is more than cm, now there is emerging data that probably adjuvant chemotherapy should be, or systemic therapy, chemo slash immunotherapy should be used on those patients. Now, when we're talking about the doses and the BED more than 100, we're talking about the most common one used for the peripheral, one, the 45 or 50 gray in 4 fractions, or 60 in 3, or 50 in 5, and the Japanese protocol 34 gray in just 1 fraction in the peripheral tumors. So these all, they were actually for the peripheral lung small tumors. But what about the central, ultracentral lesions, where you have really a risky sites there, like you have the carina, you have the great vessels, and you have the heart also. So what about that? Can you really safely treat those patients with the same doses as being used and published in the peripheral tumors? So at a point, it was said that no-fly zone, and there is a publication about that from Joe Chang, that please don't go to that area. It's very risky. When they started with the peripheral tumors, it was risky. At that time, they used 60 in 3, and they had a lot of side effects and even mortality. That's why it was called no-fly zone in the central regions. And this is the definition of the central and ultracentral region, where the lower part of the trachea, the bronchus, and 2 cm around, this will make it what we call the bronchial tree. And at that time, when they used 60 and 3 fractions, they had a lot of mortality and side effects. So it was called, and this publication, it was called no-fly zone. Don't go there and don't treat. But, and this is some of the tumors were central, or even the ultracentral, which is very close to the organ within this bronchial tree. Like this is by the PET scan, how you see the very central and ultracentral tumors. Why it was thought it's risky, and it is risky because of the chances of bronchial structural collapse, esophageal stricture, necrosis, tracheoesophageal fistula, and also hemorrhage and mortality. And one of the study actually, out of 77 patients, 2 they died on table while considering high dose per fraction, that's 60 and 3. Later on, Joe Chang, actually, he is from the MD Anderson, and he is the one who helped us at King Hussein Cancer Center to establish our SBRT for lung back in 2015. So for the last 10 years, actually, we are treating our patients with the SBRT lung whenever possible or whenever indicated. So he went in and he questioned that why not to fly in the no-fly zone, but try to change the schedule of treatment, not to consider 16-3. Why not to consider other regimen that is less dose per fraction and more number of fractions? And then, he published his study where he showed that SBRT, if you select like 60 in 8 fractions rather than 60 in 3, you may have the same outcome as if you are treating the peripheral tumors. So only change in the dose per fraction that it matters. And the outcome, and again, the other publication outcome is stereotactic ablative radiotherapy for central lung tumors. A systematic view from many studies have been done from 2013. They showed that the local control rates is about 85 if you select correctly the dose per fraction. So it is doable. It is like the peripheral one, and you can fly in that zone safely. Now, these are some of the doses that they were considered for the patients. Even in some of from the Toronto, they tried 50 in 5, and they achieved the same results as well as 60 in 8, but not 60 in 3 or 34 in 1, the Japanese protocol for the peripheral tumors. And you can see the overall, for the central and the ultracentral tumors, the overall survival local control were almost the same as if you are treating the peripheral tumors. So this is another study, a recent study to compare elderly patients with the other patients. Can safely SBRT for central, ultracentral being considered for the elderly patients? Because in some old studies, they restricted the age up to 75. But now, actually, you can treat irrespective if general condition in general is good, performance 0 to 1 or 2, you can safely consider SBRT for central and ultracentral tumors. And they showed here whether patient's age is more than 75 or less, almost the same. So again, they showed here that it is the similar level of safety, whether irrespective of the age of patients. Now, this is, again, another recent study about, again, the meta-analysis, not only for the peripheral, but this time the meta-analysis, many trials for ultracentral and central tumor. And again, they showed very good local control and overall survival as if you are treating patients with the peripheral tumors. And they concluded from this very important meta-analysis that SBRT is a treatment for the ultra central tumor and central tumor, yields high rates of local control, toxicity rates may be acceptable, and you can say it's like the peripheral one. But you have to have really a good selection of the dose fraction, the technology you should have. You should use, or preferably to use VMAT or the IMRT. VMAT, it takes like 2 or 3 minutes only for the treatment, and patients will be, more comfortable with it. And also, you should have really an experienced radiation oncologist, medical physicist as well, and the RTT. It's a whole the team to be trained for the SBRT, especially when we are talking central and ultracentral. So in the guidelines for many years now, the SBRT for central and ultracentral, it is there beside the peripheral, and these are the doses, usually 50 in 5 or 60 safely. If you want to start 60 in 80, better than even 50 in 5. Really to have a good outcome. And these are the some of the organ at risk that your medical physics and radiation oncologist should take care for the dose constraints. So SBRT, this is actually our publication when we started many years ago with the Joe Chang, that you need practice. I'm showing this, just you need practice and you need really good experience in the SBRT, especially talking about the lung and central ultracentral before commencing this at your center. So you should have the 4D. There are many now ways like the breath hold, but 4D it's mostly used. Good physics plans, and also the QA and CBCT. Of course, you should have CBCT. No SBRT without the 4D or CBCT or the breath hold. So you have to do it, the 4D, just for inhalation, exhalation, all, because we know the tumor is moving, right? Especially when the tumor is near the diaphragm. You can see here. That's why what envelope for the physics, you have to have what we call envelope isodose. Take into consideration the movements, mainly when the tumor near the diaphragm. CBCT is important to make sure, and radiation oncologists, at least in my practice, we have to be there, not only the RTT, really to make sure that the treatment is accurate with a good VMAT, good conformality to the tumors. And these are of our own, actually, patients that we treated with the central ultracentral. Like you can see here, the lesion which is near the heart, and this was treated and few months after, so the complete response of the tumor. Again, these from our own patients' data with almost complete response. We do 3 months, we do CT, don't do PET scan because of the changes after SBRT. It will not be helpful. Do it at 6 or 9 months, the PET scan, and that's the best time to evaluate. Most of the patients will have a complete response. If you have a partial response, you wait again and you see in a few months time, because sometimes it may take. Another lesions from our patients that we have treated, you can see how before and after for evaluation of those patients. Again, some we treated in 2023, again, the central tumor with 60 and in 8 patients. Now the question, can you really consider it for operable patients, for fit patients, or only for patients who refuse surgery, or patients who are unfit? There is now emerging data actually to support the use, although we are waiting some 2 large phase 3 trial. So in my gut feeling, I think that in coming few years, after the results of these 2 trials, that again it will be considered for the fit patients, not only unfit patients. So this question was thrown in 2011 that from Italy, that whether SBRT can use for operable stage 1. Can we do it? Can we offer patients like what we do in prostate, whether to go for surgery or to go for radiotherapy? Can we do that by offering SBRT for this patient? So that was 14 years ago. It was a question thrown in the literature for researcher to do. And from there, some studies evolved and trying to answer this question. And this is some of studies which showed that the local control with T1, T2 at 5 years, almost 92%, and 73 at the 2 years, almost like surgery. 5 years overall survival, again 72 and 62, and they concluded that SBRT is safe and promising as radical treatment for operable stage 1 non-small cell lung cancer. And the survival rate potentially is the same. So they started 2 studies, the Rosal study and the STAR study, randomized one, to try to answer this question: can SBRT used for operable patient? But actually, unfortunately, both they closed early because most of the patients, they went to surgery and not to the radiotherapy. But what Joe Chang did, he took those patients who underwent SBRT, right, in these 2 studies, and he followed them up. And he published 3 years and 5 years outcome. And what he showed, that the combined patients from Rosal and the STAR, that the same outcome, overall survival and disease-free survival, is the same like surgery. And again, the 5 years, he published another publication in 2021 talking about the 5 years of the follow-up, and he showed that at 3 years, the overall survival was 91, great, like surgery, and the progression-free survival 80, and the overall survival at 5 years, it was 87%, with local failure 6%, regional failure 12.5%, and this metastasis 17%. And he showed that no significant difference in progression-free survival, lung cancer, specific survival, or the incidence rate of local, regional, or distant metastasis in patients who are fit for surgery. So for this, they started, and he concluded that it is not inferior than surgery. For this, they started another 2 well-balanced, randomized trial to finally answer this question, and then we may change our practice or our options for patients to select from the stable and the failure, and we are waiting actually eagerly these 2 studies. And in as I mentioned, my opinion that the results will be the same like the other 2, but we have to wait like 1 or 2 years to see the 3 and 5 years outcome. To conclude, SBRT is a standard of care for patients who refuse surgery, inoperable patients, not only for the peripheral tumor, but also central and ultracentral. And there are some evidence to support it in fit patient, but it needs really experience, training, and also to be discussed within the multidisciplinary approach. Thank you so much. May I ask, just in addition to this, just 1 minute, the audience, do you treat lung cancer, a small one, without pathology? Who can treat? None? There should be some, please. Yes. Yeah, Dr. Atraya. Who else? Without pathology. You have a lung cancer, 3 cm in the lung, no radiologically, no pathology. Can you treat by SBRT? Yeah. The answer is yes. We know tissue is the issue, and this is the message. We know it. You try your best to take a pathology. You track a biopsy, which is helpful for many things, for molecular study, to confirm this is cancer. We have the small cell, non-small, squamous, adeno, to do some molecular studies for those. You have to try. But in some situations, we know that either we fail to take a biopsy for one reason or the other, or secondly, that patients will strongly refuse to take a biopsy. So in these 2 conditions, if you have radiological evidence of increasing in the size, like every 2 or 3 months, that radiological in CT scan, that it is increasing size, so it is cancer unless proven otherwise, because if it is benign will not increase in size. Secondly, if you have PET scan and SUV is high. In these 2 conditions, if you can treat without pathology. And there are many articles already published in literature to support this. I mean, the findings of treating without pathology. Keep that in mind. Thank you so much.